Hello and welcome back to the Psychiatry and Psychotherapy podcast. I am joined today with Michael Cummings, expert psychopharmacologist, was the head consultant in Patton State Hospital for a number of years, now semi-retired. How's retirement going?
Pretty well actually. I came back as a retired annuitant, so I'm still working part-time, but the important feature there is part-time. So,
Yeah, that's good. Well, okay, so I wanted to jump in. We're gonna get through a lot of questions hopefully today, but
hmm
I wanted to start with clozapine. And there's a new law that the clozapine REMS is scrapped,
yes,
and it happened 2 days ago. So that's February 25th, 2025.
yes.
And so we no longer need to report to clozapine REMS, which was something I did on a weekly basis for some of my clients. So walk me through what happened and what this means for us.
Basically, a number of us have been lobbying the FDA for a number of years now to do away with the REMS program, in large part because it's become clear based on research data that the primary risk for severe neutropenia occurs fairly early in clozapine treatment and then declines to a level of about somewhere between 1 and 6 per 10,000 after a year of treatment, which are levels comparable to other drugs that can affect the bone marrow. Um, and we don't have REMS programs for those. So the FDA finally reconsidered the issue, and 2 days ago they basically abolished the REMS program for clozapine and simply noted that people should exercise good judgment and follow the recommendations in the package insert. In part, what prompted this was the Europeans dropped all requirements for monitoring after 1 year. Um, I think more than a decade and a half ago now. Their rates of morbidity and mortality due to severe neutropenia related to clozapine are no larger than ours, which argued that the monitoring beyond a year does not actually serve any purpose. Um, my guess is what most individual clinicians and very likely systems like the California Department of State Hospitals are likely to elect to continue monitoring weekly for the first 6 months and then may or may not elect to monitor every 2 weeks for the following 6 months, and then may stop routine monitoring altogether. And simply, as the Europeans do, they advise and educate their patients and families that if someone develops a persisting infection or if they develop a sore throat that is not getting better, not going away, they should go and have a CBC done to look at their absolute neutrophil count.
Okay. So this is like revolutionary to the world of treatment resistant schizophrenia.
Yes.
Um, we spoke about treatment resistant schizophrenia way back in episode 49. So it may be worth repeating some of the key points that we brought forth. Um, the uh, the thing that I'm thinking about is there's a number of patients who, due to anosmia and just resistance, like maybe they'll take a pill, but to get them to draw a lab once a week has just been absolutely difficult in my
hmm
practice. But these are like the people that need it the most, you know? And so
Yes.
I'm like thinking to myself, do I is there a case for this type of patient due to the risk of them being psychotic for the rest of their life for them not to take the blood test every week?
Well, certainly it's arguable that after the first 6 months, weekly monitoring is no longer necessary because the primary principal area of risk is during the first 18 weeks of treatment. Um, and then it begins to decline fairly steadily. It peaks at about 1.3% and then declines thereafter fairly steeply. It's an autoimmune process. So um, during the first month of treatment, there's very little risk because the person has not had time to develop an immune response to clozapine or actually its metabolites. Um, and then it peaks and then it gradually declines in terms of risk in the population. I think the chief benefit, well, there's several here. One will be it's much easier to talk somebody into doing lab monitoring if it can be made clear it will not last forever. It will decline in frequency and then at some point it will go away. Uh, the other valuable point is you can now do ANC monitoring via finger stick rather than venipuncture. So that is a benefit. Other benefits related to REMS going away is there will no longer be a need to send things to a pharmacy for their review before they can dispense the clozapine. Instead, like all medications, they will be relying on the judgment of the prescribing physician to have judged that it is safe to dispense this medication.
What is let's back up a little bit because I feel like we need to prescribe clozapine more in America. I feel like this is an underutilized medication, and I think this is a good time to advocate for it.
We
What
do, because certainly in the context of treatment-resistant schizophrenia, and we went over this way back when we talked about treatment-resistant schizophrenia. If somebody has failed two adequate trials of two different antipsychotics from different classes, given at adequate dose and duration, their odds of responding to anything other than clozapine is less than 7%.
think about that, like if a patient's coming in and they're on an antipsychotic and they've been on another antipsychotic and they're not responding, clozapine is like the first medication you should think of
Yeah.
because you're going to get 40 to 60% of those people responding.
Yeah. Well,
Incredible.
many of our patients who are treatment resistant, it's clear clozapine is essentially their only real option. We don't have any other tools that are as good as clozapine. Um, aside from decreasing violence and suicide risk, it's also the only thing that's effective for treating treatment resistant schizophrenia. Um, the other element of that is if you let somebody remain treatment resistant without clozapine treatment, um, the Yoshimura study found that, after 2.8 years of treatment resistance, even clozapine's effectiveness begins to decline. Fortunately, it doesn't decline to zero. It goes from somewhere between 40 and 60% down to hovering around 30%, at least for the period of time that they studied. Um, but there are not now a number of articles that have been published that point out the benefits of switching earlier to clozapine.
We talked about a number of things, including the dose. So let's talk about the dose briefly. What do you normally start a patient on? How quickly do you escalate the dose? How high do you
Uh,
go?
for and on DSH, we differed slightly from the package insert, although the package insert's fairly close to this. First dose is 12 and a half to 25 milligrams at bedtime. Not that we expect that to do anything to the psychosis. That's mostly because clozapine is a very good alpha antagonist, very anticholinergic, and a very good histamine antagonist. So you can make somebody hypotensive and oversedated fairly easily. If they tolerate that well, the next day they can go to 12 and a half to 25 milligrams BID. And then we titrate, aiming to be at around 100 milligrams by the end of the first week, and to about 200 milligrams by the end of the second week. We rarely titrate faster than in 50 milligram increments, and that usually is at a rate of once or twice per week. We're aiming for an initial plasma concentration range of 350 to 600 nanograms per milliliter. If the person responds to that, fine. If they are still suffering from significant positive psychotic symptoms, um, we then will titrate the dose further until we get up to around 1,000 nanograms per milliliter. We do also use what's called a 2-week rule in terms of titration. This actually applies to all of the antipsychotics. If you increase the dose of an antipsychotic, what you have after about 2 weeks is 80% of what you're going to get at that dose slash concentration. So there's no reason to wait for prolonged periods before you titrate further. And for a trial, you come to one of several endpoints. One, the one you're hoping for is the patient gets better. Two, the person develops intolerable side effects, so you've gone as far with that drug as you can, and you may have to back down and come to a balance between benefit and risk. Or you reach the point of futility for the drug, meaning the odds of producing a positive response are less than 5% if you push higher. Now, for clozapine, that occurs at about 1,000 nanograms per milliliter, although I will tell you, we do have rare patients who require clozapine plasma concentrations of 1,200 to 1,400 nanograms per milliliter, and actually tolerate those concentrations. There aren't very many of those. Those are the people out in the tail of the bell curve, out in the 3 standard deviations from the mean. But we have one or two of them in the state hospitals.
Okay, so just to I have this DSH psychotropic medication guide that you gave me. It talks
Hmm.
about for a male, the average expected level is about 1.08 times the oral dose. So
Yes.
about 1 to 1. So it's like if you gave 350 to 600 milligrams, you're going to get close to that level, which is the target range.
Hmm.
For females, it's the multiplier is 1.32, and I'll put this handout in the guide and my website
Hmm.
psychiatrypodcast.com. And so the expected level is going to be a little bit higher, so you might need a little bit less
Yes.
than the
The
350 to 600 milligram dose. You might be more like 250 to 400. What do you say?
Yeah, I think that would be about right. As a caveat, we always encourage people to get a plasma concentration because indeed the numbers you're reading are based on the average metabolizer. But like most things, rates of metabolism um, vary from person to person and actually describe the typical bell curve or Gaussian curve. So that you'll have people who are slow or poor metabolizers who will have much higher levels than you'd expect, and people who are rapid metabolizers who eliminate the drug more rapidly than some people. The other caveat in this is if you have a patient who smokes, on average, smoking will roughly double the rate of metabolism or cut the expected plasma concentration in half.
Great. Okay. So another thing that comes up often is patients who get put on clozapine have a higher rate of developing OCD. Can you talk about
Hmm.
that?
Yeah, like many of the second generation antipsychotics, clozapine is an antagonist at serotonin 5-HT2A receptors, and in some people, antagonism of that receptor will induce obsessive compulsive symptoms, obsessional thoughts, compulsive behaviors. Um, it is dose dependent. So in some cases, lowering the dose, if that's feasible given the person's psychosis, will get rid of the obsessive compulsive symptoms. In other cases, you may need to add an SSRI. Our usual go-to medication is sertraline because it has very few strong interactions with other drugs via the cytochrome P450 system. Um, and then we treat them with that to increase serotonin and hopefully get rid of that particular adverse effect of clozapine. Uh, where we get stuck frequently is if we have somebody who is not purely schizophrenic, but who is schizoaffective disorder bipolar type, then it becomes very risky to give them an antidepressant, although clozapine itself is a fairly good mood stabilizer. So we have, in some cases, crossed our fingers, held our breath, and titrated the SSRI very gingerly to see if we could strike a balance between their mood stability and their OCD symptoms.
Okay, so number one, check their blood level. Try to get it down to like the effective range. Number
Hmm.
two, sertraline. What do you think about fluoxetine? Is that a decent option?
No, for two reasons. One, fluoxetine is a potent inhibitor of cytochrome P450 2D6 and will raise clozapine levels about 30%.
Okay.
The other problem I have with fluoxetine is its half-life. If the person is not tolerant of fluoxetine, or say, for example, this person actually is vulnerable to a bipolar diathesis and you didn't know that, but you unfortunately discovered it when you started the fluoxetine. Half-life is 9 to 14 days, which means washout is 10 weeks, 2.5 months.
Okay, so quiz question for my audience. You should know this if you listen to the podcast. The quiz question would be, what is the most common reason why people die on clozapine?
The most common reason for death due to clozapine is bowel obstruction.
So what is constipation, right? Bowel
Yeah.
obstruction.
Yep. Oh,
So
it's constipation that has progressed to bowel impaction, meaning there's a very hard lump of stool stuck in the bowel, followed by usually ischemia of the bowel wall, obstruction of the bowel, um, and that can have uh, produce a catastrophic outcome. That's actually has always been the most common cause of death with clozapine. It statistically it far outstrips the severe neutropenia.
okay, potential board question. So let's say you have a patient who is with Parkinson's disease, where standard treatment has failed. Is there a case for clozapine?
Yes, there is. Clozapine does not tend to engender adverse motor effects, and that's primarily because it's frankly a very poor uh, antagonist at D2 receptors. At therapeutic concentrations, the occupancy in D2 receptors is around 25 to 40%. Typical antipsychotic D2 blockade is in the 65 to 80% range. So clozapine is well below that, so it doesn't tend to cause motor symptoms. Um, in fact, they looked at, for example, clozapine as a potential treatment for tardive dyskinesia because it does seem to benefit TD in many patients. The American Neurological Society did not include it as a proven treatment, basically because it had two large positive studies and one large negative study, which no one has yet figured out why the negative study was negative.
Here's another clinical case scenario you should be aware of as a provider. Patient comes in with fluvoxamine and recently had started clozapine.
Mhm.
He is heavily sedated and hypotensive. What do you imagine is going on?
Mhm. His clozapine has gone through the roof. Clozapine is metabolized principally by cytochrome P450-1A2, for which fluvoxamine is a potent inhibitor. It basically will turn 1A2 off. Now, clozapine does have a couple of other metabolic pathways in the cytochrome system. It's also metabolized by 2D6 and by 3A4, but those are relatively minor pathways compared to 1A2. So if somebody gives fluvoxamine at antidepressant or anti-obsessional doses, they have essentially removed the ability to metabolize clozapine.
So yeah, be very careful with. I mean, that's a very potent inhibitor, which leads to very large amounts of clozapine.
Yeah, I and a couple of my colleagues reported on a case in which uh, patient was given fluvoxamine, a woman who had been on 100 milligrams of clozapine twice a day for 2 years, had a fairly responsive psychosis, was doing well, um, developed obsessive compulsive symptoms, as we've talked about. Unfortunately, the clinician who next saw her was not aware of the 1A2 inhibition by fluvoxamine and promptly put her on 100 milligrams of fluvoxamine. She died 2 days later.
Important. Okay, here's another question for you. Patient comes in, recently started clozapine, now at 400 milligrams per night. They
Hmm.
complain that they wake up in the middle of the night and they feel like they're choking,
Hmm.
and they feel like they're having some panic or something.
Hmm.
Okay, so what do you imagine might be going on?
As you know, the metabolite of clozapine, norclozapine, unfortunately stimulates the salivary glands rather strenuously and increases uh, saliva production, produces sialorrhea, drooling. In many patients, that actually increases the risk of aspiration and of aspiration pneumonia. Um, it's one of the dangerous side effects of clozapine, not as dangerous as bowel obstruction, but it's not inconsiderable either, which is why we should pay attention if our patient's developing sialorrhea and attempt to reduce the sialorrhea. We start typically with topical anticholinergic agents that can be given orally. Um, 1% atropine drops sublingually.
Eye
Uh,
drops.
eye drop. Well, yeah, they are eye drops, but they
Put in the
work in the
mouth.
mouth. They work in the mouth as well. You put it under the tongue, have the person kind of swish it around. Then after they've held it in there for 30 seconds to a minute, you give them about a teaspoon of water and have them swish and then spit the excess so they don't swallow it. Because in this case, we're um, trying to avoid them having systemic anticholinergic effects. Because that, if you give somebody who's on clozapine a systemic anticholinergic, it will roughly double their risk of developing ileus and bowel obstruction. Uh, if that doesn't work and we're stuck, in some settings, we will give glycopyrrolate. It still has the bowel risk, but does not cross into the brain, so it will not add to the person's central anticholinergic burden, meaning we won't make them dumber and have a poorer memory uh, while we're trying to treat their psychosis. Uh, if that doesn't work or it's inadvisable because this is a person who's had bowel difficulties, uh, we in the state hospitals we are using botulinum toxin, botulinum A specifically, um, to inject the parotid and submandibular glands on a 3 to 6 month interval, which works very nicely. In 90% of cases, it resolves the sialorrhea. Um, we actually stole that from the neurologists because, of course, people with things like Parkinson's disease and Huntington's chorea also have a difficult time with sialorrhea. And they started injecting botulinum toxin to control the sialorrhea. Then psychiatrists in research settings started using it in clozapine patients and found out it works just as well there.
Okay, let's go through some things that psychiatrists may not know about this. I would say one of them is that clozapine may reduce or can reduce mortality in schizophrenia patients.
Yes. The original study in this area came out of the Maudsley Hospital in London, where they looked at their clozapine patients versus their non-clozapine patients and found that those who were taking clozapine, despite all of its risks and side effects, those patients lived longer. And it was not a small, I've forgotten now what the increment was, but it was not a small percent increase in survival. Later in the Scandinavian countries, Tohanen et al. Did a very similar population-based study and found that the best overall survival among schizophrenic patients occurred in those who were taking clozapine. Second best were long-acting injectable antipsychotics, and worse were the oral antipsychotics.
Okay, number two. So I'll ask this as a question. So, so kind of like if you're listening to this, try to answer it before Cummings does. You have a patient who started on 50 milligrams a day of clozapine at night. He comes in having fallen at night while trying to go to the urinal. He also feels very, very groggy. What's the reason for this, and what is the thing that you would do next? So try to answer that in your mind.
Yep.
And then Cummings, what do you think?
Well, we already noted clozapine is a very, very potent antihistamine. Uh, this person has two things going on, antihistamine blockade, which will make them groggy. Uh, Having started at 50 milligrams at night, that's too high a starting dose for most people. Um, this would be like taking a whopping dose of 75 to 125 milligrams of Benadryl when you went to bed. Um, there are people who can tolerate that much antihistamine, but not a lot of them. The other element that may add to this is that clozapine also is a good alpha 1 antagonist and causes blood vessels to dilate, so that when the person stands up, especially if they stand up rapidly, they may have some degree of orthostasis on top of being oversedated. Well, those are a wonderful recipe for falling. So basically, the treatment for this is to go back, reduce the dose to a more tolerable level, and then titrate more slowly, as we outlined previously.
Okay. The patient comes in to the ER having been on clozapine for 3 months, having a new onset seizure.
Mhm.
Clozapine level is drawn and is at 1,200 nanograms per ml. Patient is only on 600 milligrams of clozapine a night. What do you imagine is the next course of action for this patient?
Well, next step is to figure out if they've been taking the drug as directed, uh, or if they are on any 1A2 inhibitors. In other words, you're looking for things that might have increased the clozapine level more than expected. If none of those things turn out to be true, this may just be a slow metabolizer of clozapine, in which case the next step is to lower the dose of clozapine and try to get it back down around 1,000. The risk of seizure with clozapine is related to two factors. One is the rate of titration. If you go too fast, the person may seize. If you get beyond 1,000 nanograms per milliliter, you may start to see myoclonic jerks, which are a harbinger of either myoclonic or tonic-clonic seizure. Now, if somebody has a seizure on clozapine, even at, and at a therapeutic dose that you want to keep, uh, seizure per se is not a reason to stop clozapine. It's a reason to add an anti-epileptic to prevent the seizures. Because remember, these are people for whom clozapine is likely their only viable treatment option. Most common agents are valproic acid or levetiracetam, Keppra. Valproic acid is undergoing some reconsideration, certainly in Europe and in the UK, and is likely to undergo some degree of reconsideration here in that it has reproductive risks, certainly in women, but it also appears to have reproductive risks in men as well, in that it causes methylation of the sperm, so that if a man gives rise to a pregnancy within 3 months of taking valproic acid. The rate of uh, neurobehavioral syndromes in that child are increased significantly.
On further interview, you find the patient was recently put on ciprofloxacin
Mm.
for a UTI.
Yeah, well, the ciprofloxacin is one of the medications, and indeed, but it's the only one of this group of antibiotics that is a potent 1A2 inhibitor. So essentially the same thing has happened as with the fluvoxamine. The person got put on the antibiotic, and essentially their metabolism of clozapine came to a stop, and consequently their plasma concentration began to climb rapidly, in this case, inducing a seizure.
Okay, let's say another scenario. You have a patient in the first 3 weeks of starting clozapine who develops a fever. You fear the worst, that this patient has NMS, but all they have is a fever. What is actually going on?
Fever is a fairly common adverse effect with clozapine, affecting up to 20% of those who start clozapine. It does deserve attention. Now, in most cases, it's a benign fever where the person will have an elevation of temperature for the first several weeks to months of clozapine treatment, and then the fever will just gradually fade away. The main thing that you want to be cautious of if somebody develops fever is to be sure to ask them if they have any additional associated symptoms, particularly symptoms related to the heart, that is, shortness of breath, chest pressure or discomfort, um, feelings of orthostasis. If those things are occurring, you want to be sure to rule out uh, clozapine-induced myocarditis, which is relatively rare, but very important because, of course, if people develop myocarditis, they can progress into a dilated cardiomyopathy with decreasing ejection fraction over time. The way you make the diagnosis, other than looking at the symptoms, is to get a troponin. If troponin is more than up 2 times the upper limit of normal, that's essentially diagnostic of myocyte damage. You may also want to get a C-reactive protein, because there are some cases in which the troponin does not rise as much as people would expect, but the C-reactive protein does in those cases. Fortunately, the risk period for myocarditis is fairly short. 80% of cases occur within the first 4 weeks of clozapine treatment, and essentially 100% occur within the first 6 weeks of treatment. This is this is not a problem that you will see in people who've been taking clozapine for months or years.
Myocarditis is rare, but a serious early side effect.
Yes,
In summary, troponin, get a troponin level, and it's usually in the first month of use, right?
yes, yeah.
Uh,
80% in the first 4 weeks.
Tachycardia, flu-like illness,
Mhm.
prompt investigation needed. What are the differentiation types of things are you looking at for that? So tachycardia, flu-like symptoms. That's the go ahead to kind of.
Yeah, and particularly if those are associated with additional things such as, my chest feels tight, my chest feels heavy, I feel short of breath when I walk upstairs. Um, all of those should be sounding alarm bells that we need to check this person carefully to be sure they're not developing myocarditis. If the troponin and C-reactive protein come back positive, the next steps, of course, are to discontinue the clozapine and sign the person up for an echocardiogram to see what effect has already occurred with respect to their ejection fraction. Um, Now, the vast majority of people, if you identify them, if you hold off on the clozapine, their myocarditis recovers, and just with supportive care. Can you rechallenge them with clozapine? Yes. In fact, there are a couple of published rechallenge protocols. The key element of the rechallenge is the titration is incredibly slow, meaning on the order of 5 to 6.5 milligrams per week until you get to therapeutic levels. In other words, you don't ever accelerate um, the clozapine titration until you're past the risk period.
What's the main takeaway? If someone had, let's say, the need to be on this medication,
Hmm.
or they were going to remain psychotic for the rest of their life,
Well,
and
the
they
need
decided to
is,
try it.
even though this is very dangerous, yes, you can go back and re-challenge them once they've recovered. The key to a successful re-challenge, and it's successful if done correctly in 70 to 80% of cases, is to go very slowly. Starting at 5 milligrams at night and, week one, 5 milligrams at night, week two, 10 milligrams at night, week three, 15 milligrams at night, until you're out well past the 6 weeks, and only then increasing the rate of titration. That seems to be the key to avoiding the myocarditis.
Okay, so the increased titration
Mhm.
does increase the risk of this, right?
Yes. Yet another reason not to engage in rapid titration. And in fact, I think a lot of people are not adequately aware that if clozapine is interrupted, uh, it, you have only a very brief period before you have to go back and start all over as if the person had never been exposed to clozapine. Under 48 hours of interruption, 2 days, you can start back at half what their clozapine dose was and titrate from there. If you're out beyond 4 days, you're starting over from the beginning because all of the adaptive responses in terms of their alpha receptors, their histamine receptors, their immune risks, all of those adaptations go away fairly quickly.
Okay, let's talk about what can happen with abrupt discontinuation. So if someone abruptly discontinues, what is the chance that they may re-enter into psychosis?
Very high, for a couple of reasons. And in fact, it may be more than psychotic relapse. It may also be a cholinergic delirium. Um, these are people with a severe psychotic illness that's largely unresponsive to anything other than clozapine. So if the clozapine goes away suddenly, their psychosis tends to come roaring back. On top of that, because clozapine is so highly anticholinergic, I think a lot of people don't realize this either. 50 milligrams of clozapine is as anticholinergic as 1 milligram of benztropine, trade name Cogentin. So if you have somebody who's taking 500 milligrams of clozapine a day, that's the equivalent of taking 10 milligrams of benztropine. If you stop that suddenly, this person now has a flood of acetylcholine looking at a lot of uncovered acetylcholine receptors, and they may develop a cholinergic delirium as well as the GI side effects of excessive acetylcholine activity, nausea, vomiting, diarrhea, cramping, sweating, all of those things. Uh, so that if you have to discontinue clozapine abruptly, it's prudent to put the person on benztropine and then gradually taper the benztropine. We typically don't start the benztropine at an equivalent dose. We'll shave that by half, start the benztropine, and then gradually taper it at a half milligram a week, um, so that the person doesn't have a cholinergic rebound.
Yeah, so cholinergic rebound, you'll also see things like nausea, vomiting, sweating, diarrhea, restlessness, headache, insomnia,
Yeah.
and it's going to
Uh,
happen within 12 to 48 hours of stopping.
hmm Yeah,
What
and it's often fairly dramatic and The delirium can be quite severe as well.
Do you see this as well when you're stopping someone on like olanzapine, which is fairly anticholinergic?
You can. It is less common than with clozapine, but you can. You could also see it, for example, if you did that with chlorpromazine. Of the antipsychotics, if you put them in rank order in terms of how anticholinergic they are, clozapine's at the top. Number two is chlorpromazine, thorazine. Number three is olanzapine. So you can see it with the other two. Clozapine, though, is really prone to causing cholinergic rebound if it's stopped abruptly.
Yep. So, okay, I was thinking about like how much anticholinergic that capacity of that is like 10 milligrams of cogentin. Oh my gosh.
Yeah,
And
and
I,
and we have patients, say you have somebody on not 500 but 900. You're now getting up into astronomical levels of benztropine because normally benztropine, when it's being given as a principal treating agent, the max dose for it is 6 milligrams a day.
okay, let's say you have a patient who starts clozapine and then 2 months into it, he starts complaining that he's not being productive. He no longer hears demons in his head anymore.
Hmm.
But for the first time, and you're seeing him weekly, he's complaining of not being productive with his life. He's just sitting around the house all day. What do you imagine? Why do you imagine he's starting to talk about that?
Part of it may be the first time he's realizing that his life is not being productive. People on clozapine do not uncommonly have kind of an awakening. In fact, in the early literature of clozapine, they often described people as having awakenings where they sort of woke up and said, "Oh, my life isn't what it should be," which can be an exceedingly distressing mental state to find yourself in. One, realize that you have a severe mental illness, and two, realize that your productivity, your ability to form relationships, your ability to work are all seriously impaired. Um, this calls on the clinician to do a good evaluation, not just focusing on the positive symptoms, but also taking into account what cognitive and cognitive deficits and negative symptoms the person may have. Unfortunately, we don't at this point have great treatments for negative symptoms or cognitive deficits. But there also are some things that have been tried and have shown at least modest benefit. Antidepressants may help in some cases. Um, in a few cases, they've tried things like memantine and cholinesterase inhibitors with some benefit, not huge, but some. And of course, a psychotherapeutic orientation to look at, well, what does the person want to do that would be productive? Because often people who've been, sidelined by a severe psychotic illness, their life plan was going along and then it got severely derailed. I mean, after all, if you're dealing with a head full of demons, it's sort of hard to focus on your life goals. Those go away, and now all of a sudden you're saying, "Oh, wait, what?" And that can be a very rich field uh, for psychotherapy to begin looking at. Well, what can I do? That's one of the sub focuses of CBT for schizophrenia, which I think is very useful. Now, unfortunately, since schizophrenia, starts in utero and we don't treat it until after it's well progressed, our results aren't very good. Only about 6% of people with schizophrenia maintain stable employment, sufficient to live independently, and even a smaller percentage maintain stable interpersonal relationships, such as being married and having kids.
What's the percentage on that for people on clozapine or not on clozapine?
For schizophrenia as a whole, 6%.
Even on
Uh,
medications?
yes, it is, and part of it is, it's because, frankly, we don't treat these people until the underlying pathology has progressed hugely. Kreplin was right when he termed this dementia precox or early dementia. It's really a developmental dementia in which um, the brain has been abnormal from the second trimester of pregnancy onward. We start usually treating these people when they're in their late teens, early 20s. Well, with most severe illnesses, if you let the illness run rampant for 2 decades, it diminishes your prognosis.
Yeah. Okay. So here's another patient says let's say this patient ongoing 3 months in, you have he came in initially on Risperdal 4 milligrams. You've reduced it to two. He's on clozapine as
Hmm.
well, 400, and subsequently you decide to stop the Risperdal.
Hmm.
The week after you stop the Risperdal, he says, "I'm no longer pacing around all day. I'm
Hmm.
more just sitting around doing nothing." How do you interpret this statement?
If he was pacing around all day, I would wonder if the risperidone was causing him some degree of akathisia, which uh, was was originally actually named can't sit down syndrome, which is a very descriptive name. It was named in the what is now the Czech Republic.
which which you're I know you're laughing, but I know there's someone who probably has had that who's going to hear you laughing and be like, this is not funny. This is the worst, literally the worst thing in my life, which
No,
I think you would agree is the worst thing.
no, it's a horrible syndrome. I'm laughing
Oh,
because of the unusual naming
okay, good.
um,
I got
in
to
the Czech
clarify.
Republic. No, it's not the syndrome itself is not funny. The medical history of its naming, it was originally named in Parkinson's patients who literally could not sit down. So the neurologist who was treating them just named it by, in descriptive terms.
There's an intense restlessness that's quite often occurring with antipsychotics, especially at high doses,
Hmm.
typical than atypical. Clozapine, does that cause this
No,
restlessness of akathisia?
no, it doesn't. In fact, as far as anyone can find, clozapine is not prone to cause any of the antipsychotic related movement disorders. I mean, you will see case reports of, oh, maybe clozapine caused an atypical form of this or that, but there's not really been any convincing data that clozapine causes Parkinsonism or akathisia or dystonia. And in fact, in most cases, it's actually something of a treatment for all three conditions. Um, and that's because, again, the dopamine D2 receptor blockade appears to be the source of these movement disorders. In the case of akathisia, there's also dysregulation of noradrenergic and serotonin receptors, which is why akathisia is harder to treat. Um, Akathisia is the only one of the movement disorders that has been clearly identified to cause an increased rate of suicide. And that's because, as you point out, it is truly a miserable condition in which the person feels restless. I think one of my most articulate schizophrenic patients once described it as he said it felt like there were ants crawling up and down the bones in his legs, um, which I can understand why somebody would, you know, if that kind of feeling is going on, it's a truly miserable condition.
Yeah, just absolutely miserable. Every psychiatrist should know about this. It should be on the forefront of their mind when they're treating patients because it can happen
It,
from a number of different psychiatric medications, and it should
yes,
be.
anything that particularly interferes with dopamine transmission in the nigrostriatal pathway, if you, particularly in somebody who is a younger patient in whom the dose has been increased relatively rapidly, somebody comes in, they're agitated and they get, a lot of haloperidol or a lot of risperidone over a fairly short period. So they go from zero exposure and blockade to a lot of exposure and blockade. If that person's exhibiting restlessness and they're pacing, odds are they're taking too much antipsychotic. Again, that's another point for um, measuring blood levels. Uh, Measuring a blood level can tell you if you're beyond the point of futility of the drug, because once you've reached the point of futility, increasing the dose for most of these drugs is not providing the patient with any benefit. It's just increasing the intensity and severity of adverse effects from the drugs.
Yeah. I've had a couple people reach out to me of chronic akathisia. Um, I'm curious, what are the treatments that are known? Do you just stop the agent? I had one person develop it after decreasing their
Hmm.
SSRI or being on the SSRI for a long time. Any thoughts around that?
When people develop tardive akathisia, it is one of the most difficult of all the movement disorders to treat successfully. Acute akathisia is fairly responsive to either beta blocker, propranolol, or to mirtazapine. Um, Tardive akathisia is miserably less responsive. Drugs that have been used include things like clonazepam, often at relatively robust doses. Um, Vitamin B6 has been used with mixed results. Uh, Lowering the dose or switching to an alternative drug may be beneficial. People have also tried other GABAergic agents like gabapentin or pregabalin. Um, Bottom line with all of these is yes, they produce some effects, but none of them have emerged as a wonderfully robust treatment for tardive akathisia.
The time course is usually different than acute.
Yeah, acute akathisia usually occurs beginning within, well, anywhere from hours to days after exposure to a dopamine antagonist. Um, Tardive akathisia often emerges after the person's been on a stable dose of something that is a dopamine antagonist or a drug like an SSRI that decreases dopamine release, often for months or years. And the person, even though they've been at a stable dose for a long period of time, they will begin to develop uh, signs and symptoms of akathisia, usually starting with the internal sense of restlessness and then eventually spilling into overt movement.
Would there ever be a role for increasing the antipsychotic in this type of issue, or is it always decreasing?
It's always decreasing. If you increase the amount of D2 blockade, um, it will tend to worsen the akathisia. Now, you can get away with that in tardive dyskinesia if you increase the amount of D2 blockade in TD. It will temporarily mask the movements. Now, the unfortunate part is the temporary word. Uh, the receptors will adapt and the dyskinetic movements will reemerge, and you can wind up chasing that so that each time you increase the dose, it gets worse. Now, one thing with TD you have to watch out for is if you decrease the dose or you stop the offending agent, the dyskinesia may get much worse for a while because you're adding a withdrawal dyskinesia on top of the tardive dyskinesia. With all of the movement disorders, I think the key element is to be aware of them in your patients and be sure that you routinely check to see if your patients have any evidence of dystonia or akathisia or tardive dyskinesia, because all of these syndromes are more treatable the earlier they're caught.
Awesome. Okay. As you're thinking about clozapine, I'm glad we covered this again. Um, what are the common issues that you find psychiatrists have regarding this medication that you continually are telling people over and over again that we haven't covered? Let's restrict it to what we haven't covered.
I think the most common thing I see, or the most common question I get regarding clozapine is, can I combine it with other antipsychotics? And the answer is yes. Um, like most polypharmacy, you're looking to combine different mechanisms of action, hoping for additive benefits across drugs. It makes no sense to combine two things that essentially do exactly the same thing because that's inherently no different than giving somebody more of, one or the other. The nice thing with clozapine is it blends well with both the dopamine antagonists and the partial agonists because its mechanisms of action don't appear to have anything to do with blockade of dopamine receptors. Uh, we think it acts, one, by increasing glutamate signal transduction, and particularly in the frontal lobes, and also by decreasing dopamine release by stimulating muscarinic 4 receptors in the ventral tegmentum. So it's not hitting the same sites as the dopamine antagonists or the partial agonists. So it combines well with both of those groups. The only antipsychotic you cannot combine clozapine with is the very newest one, xanolamine slash trospium, and that's because of clozapine's anticholinergic effects. It will essentially wipe out xanolamine's mechanism of action, which is dopamine muscarinic agonism at M1 and M4 receptors.
You probably would want to avoid any CYP1A2 inhibitor
Yes.
to combine it with, like chlorpromazine.
Yes. Yeah, with clozapine, you do not want to give the person a 1A2 inhibitor because, as we've talked about, you may well um, do the patient in if it's a potent inhibitor. If you give a more modest inhibitor, you need to be sure that you are adjusting the clozapine appropriately to maintain the person at the right level. Similar issues arise in people who develop severe infections. I mean, people are, given our recent history, people are well aware that COVID-19 could increase clozapine levels. Frankly, any infection that causes a severe enough immune response can do that. And it's because it's not the drug that directly increases the clozapine level. It's the fact that interleukin 6 and interleukin 8, two of the cytokines produced by more severe infections, inhibit the cytochrome enzymes.
What's the second most common question that we haven't covered that gets asked?
People often ask, well, what should I absolutely stay away from if I'm treating somebody with clozapine? Um, and although we've touched on this, basically anything that is a very potent 1A2 inhibitor, some of which are well known, like fluvoxamine, and some of which are relatively unknown, like ciprofloxacin. I always encourage people, if you're going to combine a drug that you're not very familiar with something like clozapine, look up its effect on the cytochrome system. These days, with the internet, that information is readily available from a number of sources, including uh, Wikipedia. If you enter a drug name, one of the things that you'll commonly find there, although they're stealing it from PubChem, is, what are the effects on the cytochrome system?
Enoxacin is another antibiotic. Is a potent CYP1A2 inhibitor.
Hmm.
Caffeine is
Uh,
a weak inhibitor.
yeah,
Wonder
caffeine's a weak inhibitor.
what if they're drinking 8 cups a day?
They may get a 5 to 15% increase in their clozapine blood level. And you have to watch out the other way too. If somebody starts taking or doing something that is an inducer at 1A2, they can lower their clozapine levels and may have a psychotic relapse because they've become subtherapeutic. Probably one of the most common that we've run into in the state hospital system has been the proton pump inhibitor omeprazole. It is a weak to moderate 1A2 inducer. Now, in most people, it's weak enough that you don't see a huge change in clozapine or olanzapine levels, but in a few people, you'll get a 30% drop in their plasma concentration, which in some people that may be enough to trip them into having a psychotic relapse. So it's good to pay attention to what may induce or inhibit the cytochrome system, um, and thereby alter you know, the concentration of your clozapine or other drugs for that matter.
Let's say you had someone on ziprasidone. Would you be concerned about QTC prolongation?
No. Uh, we do get that question as well quite a bit. Clozapine is a very weak inhibitor of the potassium rectifier channel, also known as the hERG potassium channel. This is the channel that lets potassium out of myocytes, thereby allowing them to repolarize and be ready for the next cardiac cycle. If you inhibit that, the heart can't repolarize, and you may have first prolongation of the QT interval and eventually a risk of torsade de pointe. Um, Clozapine only very weakly inhibits that channel. Um, Concentrations of clozapine that are clinically significant for doing that are above 1,500 nanograms per mil. By that point, the vast majority of people couldn't tolerate clozapine anyway. But in overdose or in cases of where the metabolism has been inhibited, that is the likely cause of death, sudden cardiac arrhythmia, like the ciprofloxacin case we talked about, where the person's level suddenly went sky high.
Okay, next question. Would
Mm-hmm.
you fear putting someone on a tricyclic antidepressant if they're on clozapine due to risk of lowering the seizure threshold?
I would do it cautiously. The tricyclics, I would consider carefully the anticholinergic characteristics of the tricyclic, because of course that's additive with clozapine. Again, I would also look at the tricyclics alpha adrenergic antagonism, because that's also additive, and its antihistaminic effects. So there's a rich possibility of additive adverse effects. Uh, Frankly, my major concern and the reason I don't use tricyclics very much as an antidepressant treatment uh, has nothing to do with clozapine. It has to do with the fact that they can inhibit the cardiac conduction system. The LD50 for tricyclics ranges from around 6 to 8, meaning that 6 to 8 times the therapeutic concentration is enough to kill 50% of people.
Let's say the patient is a heavy tobacco smoker,
Mm-hmm.
smoke actual cigarettes, and how much would that change the clozapine level?
If you have somebody who comes along and they're not a smoker or they've not been smoking, say they've been someplace where they couldn't have access to tobacco, and then they resume smoking, on average, that will roughly cut their clozapine plasma concentration in half. It will take them about 2 to 4 weeks for their clozapine level to drop that much, because what's happening is the several of the polycyclic compounds in cigarette smoke are very impotent inducers of the cytochrome P450 system. So you're ramping up their enzymes, and the enzyme is chewing up the clozapine, the 1A2 in particular, as well as the 2D6 and 3A4. The other thing you have to worry about is if you have somebody who's a consistent smoker, they're a pack a day person, and they finally listen to health messages and say, I'm going to stop, and they do. Same thing. Their clozapine level is going to double over a little longer period. It takes a little longer to go the other way. It's about 4 to 6 weeks. But you can wind up with either the person becoming subtherapeutic or the person becoming toxic. It's an important discussion to have with people who may be smokers so that they're aware that if they change their smoking habits, it will change their clozapine level. And they need to, if they decide to start smoking or they decide to stop smoking, they need to let you, their clinician, know that so that you can monitor what's happening and adjust the clozapine appropriately.
Okay, so let's see if people are listening. A patient is a heavy tobacco smoker, smokes 1 pack per day, switches to vaping the exact same amount of nicotine per day. How much do we expect the clozapine level to increase or decrease? And the answer is
It will roughly double.
this is something that I've thought about because I had a patient who was smoking cigarettes and then would stop and start vaping.
Hmm.
I had to like chase the dose.
Yes, you're chasing you're chasing that plasma concentration because indeed cigarette smoke induces the liver. Vaping of nicotine does not.
Okay, let's say you had a patient who was smoking marijuana. How might that impact their psychosis while you're trying to treat them with clozapine?
Well, marijuana, well, particularly in younger people, is psychotogenic in some. It's estimated that among marijuana smokers, delta 9 THC, the active ingredient to get high, produces some degree of psychosis in somewhere between 8 and 12% of those individuals. Now, if somebody already has a psychotic illness, marijuana may make it worse. We don't have really great numbers on that. In terms of inducing the liver, marijuana cigarettes, joints tend not to be as bad an offender as tobacco, largely because people don't tend to drink, don't tend to smoke 20 to 40 joints a day. Even a heavy marijuana user will typically not smoke more than around 6 to 8 joints in a day's time. So it's purely an effect of how much. The same polycyclic compounds occur when you burn marijuana leaves as occur when you burn tobacco leaves. But in the case of tobacco, people are often smoking a lot more. And of course, but then you have the issue of delta 9 THC itself is psychotogenic for some people.
What does clozapine do to brain-derived neurotrophic factor?
Increases it. Also increases glial-derived neurotrophic factor as well as epithelial-derived neurotrophic factor. Increases all three. Now, we are presuming that is a good thing, and you do see cortical thickening in people who are treated with clozapine, largely due to increased dendrite arborization. Those are the short projections from neurons that tend to receive signals. And for all the world, if you're looking at them under a microscope, they look like small bushes. Well, if your bushes have kind of lost their leaves, if you will, you have cortical thinning as a result. If they get bushier, you get thickening. We presume that's good, and it seems to correlate with improved cognitive and attention and processing performance in people treated with clozapine. Uh, we don't know all of the details of the responses to brain-derived neurotrophic factors well enough to know in detail what the clozapine does downstream, but we're assuming at this point that it's good.
There was a 2018 study that it showed clozapine decreased IL-6 and TNF alpha
Mm-hmm.
patients, which may be another potential mechanism, anti-inflammatory properties.
Yes, which may be a benefit because one of the things we've discovered is that abnormal inflammation appears to play a role in the pathophysiology of schizophrenia. And indeed, the increased inflammatory response over time may be one of the mechanisms by which people with evolving, well, I should say people evolving towards schizophrenia are losing synaptic connections in neurons is via abnormal inflammatory responses.
What do you think about the genetic studies showing polymorphisms in genes like DRD3, dopamine receptor D3,
Mm-hmm.
and COMT, catechol O methyltransferase, which is associated with treatment outcomes?
Mm-hmm. Basically, I think we're gradually beginning to understand some of the genetics and epigenetics of schizophrenia. I just wrote a review paper for CNS Spectrums entitled "What is the Neurobiology of Schizophrenia?" One of the early parts of that paper noted that, we've discovered that there are 240 gene loci associated with risk for schizophrenia. And those include not only 108 single nucleotide polymorphisms, but also things like DNA transpositions, DNA deletions, DNA recursions where there's more than one copy of a DNA strand. Interesting when you look at them kind of en masse, it suggests that signal process, the genes that are involved or that seem to crop up over and over again are genes involved in modulation of signal processing, genes involved in migration of neurons, orientation of neurons, growth of axons, cell adhesion, um, which is why I think again Kreppelin was right in calling this a developmental dementia in which the gene abnormalities give rise to both an anatomy and a physiochemistry that aren't what they should be, that aren't truly healthy, which is how these people get into having a progressive an illness that is largely genetically determined. Schizophrenia is about 80% determined by genes, about 20% by environment. There are things you can do to people that will make it more likely if they're genetically loaded that they will become overtly ill, and those include things like childhood adversity, infection of the mother during the second trimester, interestingly, growing up in an urban as opposed to rural environment, and exposure to things like cannabis during adolescence or other drugs that are tend to be neurotoxic, like methamphetamine during adolescence, can worsen the risk that the person will develop an overt psychotic illness.
Let's say the patient has schizophrenia and catatonia. Let's say they've had a history of responding well to clozapine in the past, but they've been off medications for a while.
Mm-hmm.
What would you treat first and why?
I would probably start with the catatonia. One, the clozapine treatment is going to take longer to get in place. I would start, frankly, in somebody who I suspected of having catatonia with doing a Bush-Francis rating scale and get a good sense of, what catatonic signs and symptoms they were exhibiting. I would then give them a lorazepam challenge, which is 2 milligrams via the intramuscular route, and then I would reevaluate the patient after 45 to 60 minutes to see if their catatonia had ameliorated or gone away. An important caveat with that is it should not be by the oral route because the peak will not be high enough and the onset will be too slow. Uh, if the lorazepam challenge is positive, they're then going to get put on standing either lorazepam or clonazepam to control their acute catatonia while at the same time instituting antipsychotic treatment. Not excessive D2 blockade, but either moderate D2 blockade or uh, initiation and titration of clozapine, or perhaps both, depending on the person's history. Uh, an important caveat with catatonia is always a secondary syndrome. It's always catatonia due to something. Now that the something can be a whole list of things, ranging from schizophrenia to neurologic conditions to medical conditions to mood disorders. Um, and so you ultimately have to treat the underlying condition if you hope to control the catatonia, but you can control the catatonia relatively quickly. Now, if the person's not a responder to a lorazepam challenge, that doesn't mean that they don't have catatonia. It just means that they're not a benzodiazepine responder. And that person is going to get moved along to ECT fairly quickly.
So, some of the most common things on the Bush-Francis scale that we would see are mutism, not speaking, immobility, stupor, which is being abnormally still or unresponsive, staring with this kind of fixed gaze, and negativism, resisting instruction. Uh, those are some of the most common.
Mm-hmm.
So if you were to see someone with that, I'm curious what. So you're saying one, inject them with 2 milligrams Ativan,
Hmm.
see them back 40 minutes later.
Yeah,
Um,
that can, when that's a positive test, it's often exceedingly dramatic. Last person we did that with, this guy, um, man, mid-30s, nursing found him basically standing naked in his room staring at a light bulb. And his roommates reported he had been standing in that same position staring at that light bulb for about 2.5 hours. Mute, non-responsive, um, occasionally would switch into excited catatonia where he would kind of run around the room and touch all the walls and then go back, stand in the same spot and start staring at the light bulb again. He got 2 milligrams of lorazepam, and 45 minutes later, he was dressed, conversant, and asking what he could have for lunch.
it's truly fantastic. I once injected someone on a unit, and it was right before lunchtime. So his family came, and I came out to talk to him while his family was there. And his family was like, "Doctor, thank you so much. We have our husband back. He's so much different." And I was like, "Oh, tell me, like, what's different?" He's like, "He's
Mm.
talking. He hasn't talked to us." Oh,
Yeah,
and it was just,
yeah,
it's, you feel so good as a psychiatrist.
yeah, it's an amazing difference. Now, the other caveat that goes with this is a very important take-home lesson for people is if you have somebody who has catatonia and they're a benzodiazepine responder, do not be in a hurry to take them off the benzodiazepine because benzodiazepine withdrawal is one of the causes of catatonia. You often wind up titrating them to relatively high doses, 6 to 12 to 18 milligrams of lorazepam a day is not uncommon. Now, if you switch them to clonazepam, the dose is half. Um, but you should then plan to be keeping this person on the benzodiazepine for a period of usually months with a very slow taper, not faster than a milligram of lorazepam a month or a half milligram of clonazepam a month, because you want to be sure the underlying conditions in control and the catatonia is in control. Now, the vast majority of people, you can eventually taper them off and they're done. You will find a very small number, probably somewhere between 5 and 10% of the catatonic population who you will get down to a very minimum dose of
Ativan.
or clonazepam, and you will find you can't go any lower.
And
Because when,
can I just reiterate, like, guys, if you take one thing from this, do not pull your patients who have catatonia off of lorazepam too quickly. 1 milligram a month, 1 milligram a month. It is like, that is such a pearl, because so often people are like, well, I know they responded to Ativan. Now I need to prepare them for ECT. So I'm going to take them off the Ativan and wait 2 weeks for them to get to ECT. It's like, no, don't do that.
no, because you'll have a severely catatonic patient again. Because again, abrupt discontinuation um, will induce the catatonia.
Yeah. And I would say, like, when I would go on the unit and I would see maybe 50 people when I would cover on the
Hmm.
unit, which sounds crazy, but that used to be how I would do call. You see everyone for like 5 or 10 minutes. Um, I would inevitably catch one of them with catatonia who had not been diagnosed.
Hmm.
And because I was always looking, it's the one thing you need to catch. You need to catch every catatonic patient. Sometimes they repeat the same thing. So you ask a question, they answer it, and then you ask another question, and they repeat the same thing that they said again for the prior question.
Yes, they will perseverate or they will echo what you said. They'll repeat the last part of your question.
Yeah, you go like, "So how do you feel today?" And they'll go, "How do you feel today?
Yeah.
How do you
Uh,
feel today? How do you feel today?"
Yeah, echolalia. You'll also see the praxis version of that, where if you move a certain way, they will do a mirror movement.
Or stopping drinking. If they stop,
Mhm.
if you have a patient that ever stops drinking water, okay, who's not on a GLP-1, maybe catatonia.
Well, it's estimated that probably about 10% of schizophrenic patients at some point in their course will exhibit catatonic symptoms.
And autism spectrum disorder has a high
Hmm.
rate too.
Yeah. As do, of course, all of the mood disorders, particularly the depressive disorders, and as well as a variety of neurologic conditions and inflammatory diseases. All of them can exhibit catatonia. So I really encourage people to read through the Bush-Francis scale and kind of commit those signs to memory. And then every patient you see, just look them over and see if you see any of those. And if you do, take a closer look.
There is a significant neglect of their basic needs. They stop eating, they stop drinking. Maybe they've lost 20 pounds in the last couple months. Like,
I have seen more than one catatonic patient actually misdiagnosed as, oh, he's got adult failure to thrive. Well, no, he's not got adult failure to thrive. He's got catatonia.
or if you're treating enough patients, you'll have the spouse bring in the patient. They say, I don't know what's going on. He doesn't talk. He just sits there. And I'm like, well, when he's sitting there, is he watching TV? No, he sits there and does nothing.
Yeah.
I'm like, well, is he on like his phone scrolling? No, he's just sitting there. And it's like, oh, okay. Wow, we've covered a lot today. This is good. I feel
We
like
have.
I feel like this is uh AI pharmacology, Dr. Cummings. It's like I
Yeah, I think you told me you got a lot of the questions from was it Chat GPT?
well, this in this case today, we were going to go through the 50 most common questions asked
Ah,
on X, but we didn't get to that. I instead, because of the clozapine
change in
REMS
REMS.
being
Hmm.
dissolved, which which is so nice. This is like such a big. It's like one barrier for treatment, right? We shouldn't increase the barriers for treatment. Um, so it's been dissolved, and so now we can work directly with the patient and not have to log on to a cumbersome website, which was it was cumbersome. I always would have to log on twice for some reason.
Um,
Like,
yeah,
go ahead.
frankly, I'm not sure where the FDA got the programmers for that, but they were not the cream of the crop in terms of software creation.
So okay, I think we're wrapping it up. I think this was a good amount. Um, and I always, whenever I see like anti-psychiatry people on X and they're like, psychiatry is not a brain disorder. I'm like, do you want me to send you some catatonic patients? Because like, honestly, you will not be able to. Would you like a catatonic patient to move in with you for 1 month? We should have a program that we can like lease a catatonic patient to these anti-psychiatry people.
Yes.
They'll say like something like, well, this is not what you really do. Don't lie. You're being deceitful. And it's like, no, I
Yeah.
really do treat catatonic patients.
Yes. Well, not just catatonic, but people with severe mental illness. That is brain, and these are brain diseases. You can take a picture of the changes. You can do the genetics, and all of it points to this person has a brain that is not put together right and is not working correctly, and we're trying to coax it into working the best we can manage.
Or, depression. It's like if you have frontal temporal dementia, your risk of dementia is like, or depression is like 40%. So it goes way
Yes.
up. If you have uncontrolled diabetes, your risk of depression goes up fourfold, or something like that. It's like there are real biological impacts on our bodies. And in the same way, we like exercise, diet, all of that stuff
Hmm.
improves the risk
Yes.
of depression and mental illness. How do you think it does that? It does that by changing the brain and making the brain healthier. Um,
Yeah, I'm not sure where this idea came from that somehow the brain is not part of the rest of our biology. It seems I mean, inherently, it's just an absurd idea. Uh,
Well, but like in defense of people who are therapists who are focused on talking to patients,
Hmm.
you know, it it does make sense that they're focused on that lane, and I'm all for it. Like do
Yeah.
psychotherapy as
Well,
well. Like that changes the
yeah.
brain.
Yeah, it changes the brain. But there, I mean, that's the whole thing. With psychotherapies, you're either engaging in an exchange of behaviors or an exchange of ideas, but you're exchanging them with a brain. You know, it's not like the brain is off somewhere doing something else. Uh,
A couple things I've been thinking about is creatine. There's some new studies on creatine, and
hmm
there's one for creatine added with CBT for
hmm
depression. The group that was on creatine had like a 5 point better change
hmm
than the group on the placebo. So I'm like, I've
Yeah.
been watching these studies for years, but that one seems to have pushed me over the edge to recommend it to most people.
Well, I think the area we're and it's an area we've been kind of some people have been doing research and poking around in for a long time is are there things we can get people to do that would enhance neuroplasticity? Because when we apply a treatment, whether it's medication or psychotherapy, the more plastic, the more changeable the brain is, the more bang we get for our buck out of the treatment. And certainly some things like creatine, some things like, as we've talked about frequently, um, sleep, exercise, all of those influence how plastic the brain is.
Neurotrophic factors are some way of measuring neuroplasticity.
Hmm.
Um, so creatine, I've also been thinking about microplastics. I wrote a paper with a colleague, two
Hmm.
colleagues on this. Recent study showing a spoonful of plastics found in the brain four
Yes.
times more in people with dementia. It's concerning.
Uh, yeah, unfortunately, we have polluted the world with microplastics. And that's not a good thing because these are molecules that do not degrade easily.
Here's my hot take. Okay.
Hmm.
So zebrafish, when subjected to a high microplastics environment, it took them 70 days to get out 75%. Okay. So there is an elimination that goes on. And if
Yes.
you looked at the histology of the recent study that came out on microplastics in the brain, the microplastics are in the white blood cells in the brain.
Yes.
My hot take is number one, we have to figure out how to reduce it from our intake. And when I looked at everything that possibly can be, uh, probably the biggest bang for the buck is to not microwave plastic ever
Hmm.
when you heat up your food, like, and to never do anything hot with plastics, right? So tea bags, microwaving baby bottles that are plastic, awful, just awful.
Yeah.
um, Secondly, things that are produced with plastics, like highly processed foods. Chicken nuggets have 30 times more microplastics in them than chicken breast.
Hmm.
So those are some easy wins. The next one is traffic. When you're stuck in traffic, recycle the air in your own car and make sure you have a good filter.
Yep.
And then at home, you could get a HEPA filter. I've gotten some since I started looking at this. And that can be an easy win to
Yes.
reduce the consumption while you're sleeping.
Yeah.
Um, Speculation, there's a lot of speculation here. And I think that this field is gonna explode in the next decade with lots of studies, because it's like it's environmental psychiatry that is just completely unexplored.
Yes.
And so I'm writing a paper with some colleagues. We're looking at creating a microplastic index,
Hmm.
which will have kind of an estimation of like, okay, if you do these types of things, you may have this much microplastics. So then we can compare that to trials that are already out there and see if that correlates at all to mental health issues. Because it's kind of a
Hmm.
like we
Yeah.
don't know how much this is impacting us.
Right. Right, because we don't understand that much about the effects of microplastics in the brain, which is an area that we need to study much more since the microplastics are ubiquitous. And unfortunately, despite all the talk about plastics and about global warming, frankly, we produce more plastic and more greenhouse gases each and every year. Last year was the largest amount in history, and this year is looking already to outpace that.
It's interesting. Like I feel like, despite the executive order to bring back plastic straws, I think that when both sides of the aisle can definitely get behind, like we should probably not keep putting plastics in the ocean. Like
No,
we should get these plastics and like out of our water supply. We should, you know, like please, like have like both sides should be like 100% on board with this. Like this is not going to disrupt the oil cartels. It's not going to disrupt, you know,
well,
like we
yeah,
need we need to do
it,
something about
it
this.
it should be. Unfortunately, there are people in positions of power who just deny that this is a problem.
Yeah, and how we execute our distribution of the literature and the science, I think hopefully we'll engage that more. But
Yeah.
I think that's one thing that I've been thinking about. Anything that you've been like really into in the last couple months, just that's kind of on the forefront.
Uh, Basically been looking a lot at looking for really data that might suggest how, in particular, when we might be able to prevent schizophrenia. Um, and I think it comes to, well, the two elements in that are we need to be much better at being able to identify who's truly at risk, which I think is going to come down to understanding the genetics much better than we do. And two, then designing socially acceptable strategies for preventing some of the excessive neurotransmitter excursions and inflammation that appear to give rise to the progression from genetics to overt illness. I think we will get there. It's a very
Hmm.
slow process, and it's I think the only way that we're going to truly make a dent beyond what clozapine offers in improving schizophrenia, both with respect to decreasing the incident rate and also hopefully ameliorating the severity of the illness.
So what would be like the biggest wins that you could say like to prevent schizophrenia that you
Well, if we knew who was at risk, that is, we could do a gene association study at birth, basically, and say, okay, this infant's got, not any risk. This other infant's got a huge risk. Well, maybe this one that's got a huge risk, they ought to be on a dopamine modulator from birth onward or an anti-inflammatory from birth onward. We don't quite know what those choices should be yet. The PACE clinic in Australia has done some preliminary studies where they looked at the children of schizophrenic parents who have a 40 to 50% risk of developing schizophrenia. And they put their sample on either placebo or very low dose antipsychotic dopamine antagonist. I think it was 2.5 milligrams of olanzapine or a half milligram of risperidone. Um, they got a five-fold reduction uh, in conversion to overt illness in late adolescence. That needs to be replicated. But the reason we can't apply that more broadly is most people with schizophrenia are not descended from two parents with schizophrenia. They're spontaneous cases, and we can't prospectively tell who those people are.
Yeah, this is going to be tough. I mean, trying to sell parents to take put their kid on a low dose of an antipsychotic is like pretty. I
Well,
don't know.
it's
My
it's
hesitancy towards that's pretty high. Also,
well, it's if you think about it though, the risk from that sort of dosage slash concentration of a dopamine antagonist is exceedingly minimal. That compared to the impact of schizophrenia might make it worthwhile.
I think the what about other things like recognizing that really need to stay away from marijuana, recognizing that
Yeah.
they
But
exercise,
those things would
diet,
all
try to
help.
reduce adverse childhood experiences at all, if at all possible.
Those would be beneficial, but remember, this is an illness which is 80% genetically determined, 20% environmentally determined.
Right. So genes
So,
have no.
so, so if you improve all of the environmental things, you can reduce risk by 20%. If you can find some way to alter the phenotypic expression of the genes in a way that produces pathology, you could potentially reduce the risk 80%.
If not anything else, if you had a genetic type that you kind of had labeled like, hey, parents, this is an increased risk of schizophrenia. This is how it
Hmm.
looks. This is how it presents. If, in the adolescence, this kid starts to have these issues, like come and see a
Hmm.
specialist and let's really plan ahead on strategies for early treatment, early intervention, because it's going to be a long journey.
Yeah.
That seems like a viable option for me as well. I don't know if you thought about that. Just like
Yeah, well, certainly, again, if we got better at predicting who's at risk, we could then monitor them much more carefully.
any idea on how, because we have the genes that are abnormal. I mean, do we have a risk calculator? Has that been developed?
No, we don't. It should be. Part of it is the genetics of the illness are so complicated. Altogether, if you just count number of gene sites that appear to be related to schizophrenia or the risk for developing schizophrenia, there are 240.
I think
Now in those, you have 108 of those are single nucleotide polymorphisms. Now, if you did the gene-wide association study so that you identified all of these, the next step is indeed then the data we're missing at this point is we don't know clearly how many or which of these abnormalities have to be present to essentially form the critical burden for developing a psychotic illness.
what we really need is we need like one of these countries, if the US would be game, or some European country, to do genome mapping on all of their whole
Yeah,
population.
yeah.
And
And
then,
that I think will be the next step because
yeah,
gene analysis is going to become much more common because it's become cheaper and easier. And I would imagine in some countries they're likely to do, A to Z gene mapping of the
yeah.
individual at birth.
And I think that to me is not overly intrusive, and it's not like a bad idea. It makes sense. Like in your medical record should be your gene map, which should have a list of things that doctors could look at that are potential linked to various diseases. Like if I think with AI and the way it is, if you had a gene map for everyone in the population and you had like you could tag them all with
Yeah.
like what diseases they had, the AI could quickly tell you what is the best algorithm for predicting future schizophrenia.
Yes. And not only schizophrenia, this will be useful more broadly for, it could be very useful for a new infant to know, well, over this person's lifetime, their risk is elevated for the following illnesses.
The problem with that is the psychological weight that that puts on a parent. And so I feel like you almost like need to increase the education level of the average person before you release something like that, because if a parent hears, oh, my kid has a 20% risk of this thing, it could feel like a doomsday to them. Like
Yes.
psychologically they may not do well with that
Yes.
information.
Yeah, no, it's very difficult because, the few autosomal dominant illnesses we do have where you know what the risk level is, those obviously are devastating for families.
Yeah, so I think that's my other thought is like, okay, this can feel really weighty to a population. So it's like,
Hmm.
how do you allow this to be something that's a positive and not like a detriment?
Yeah, we're going to have to get a lot better at genetic counseling.
The intellectual knowledge of the the average person is going to have to increase. When I,
Hmm.
when sometimes they can't name the, some very basic facts about DNA or RNA, it's like it's
Hmm.
hard. It's hard for very complex topics like this to be widely adopted. So
Yes, hopefully we will get there.
Well, we will leave it there today. Hopefully, you enjoyed this conversation with Dr. Cummings. If you did, let me know. I'm on X. You can tweet this out with your thoughts. I really love hearing that. I can see that, or on Blue Sky, or on Instagram, or just shoot me an email message. And Dr. Cummings, thank you so much for
Okay,
your
thank you.
continued wisdom. I really appreciate you. And
Okay,
we'll leave it there for today.
okay, thanks.